Hi everyone, and good morning, good afternoon, good evening, depending on when you're watching this video. I am recording Chapter 10, which is venipuncture procedures, which in your textbook starts on page 308. So right there's chapter learning objectives, and then our NACLs, entry-level phlebotomy competencies that we're going to address in this chapter. And as you can see, it's on venipuncture procedures. I also want to note my co-workers that are here with me at my home, i.e. my dogs, may occasionally bark in the background. I'm very sorry for the disruption, but my co-workers don't seem to know that they need to hush their mouths while I'm trying to teach my class. So bear with me. There's lots of things we're all having to bear with while we're doing moving to this online course. But I really wanted to make sure I got these videos recorded for you guys and up so you can start going over them, reading your chapters, filling out your study guides, and studying for your next test, okay? So up here on the screen, as you can see, and you guys can utilize your pause and rewind, is our learning objectives. I'm not going to read each and every one of them to you. Two things I want to point out immediately up here are hand washing and patient identification. As I preach to you guys all the time, and you know this, I talk about hand washing, which now with COVID-19, you can see that hand washing is one of the best ways to stop the spread of infections, and some of these infections can be much more deadly and easier to spread than others. And then, of course, we're going to go into patient identification and how important that is, okay? So, getting on with it, if you look in your textbook on page 312, it's Procedure 10.1, you'll see dealing with preparation for patient encounters. On page 314, we talk about preparing for the patient encounter. On page 315 and 316, you can look at hand hygiene and putting on or donning and doffing, taking off of your gloves, and the proper way to do that. Okay, and we've went over these things in lab before. The main high points I want to hit from here, and you guys bear with me, I'm going to try to zoom in here a little bit because I do know the video quality is not the best, but I know you guys can read this. So, but I want to just zoom in here. So, the things we want to look at with gloves is that you want these patients to see you putting on the gloves, okay, so that they're aware that you washed your hands and those are fresh, clean gloves, and you're not, you didn't put them on outside the room. They'll think you came from somewhere else. So always try to do that in the presence of your patient. We talked about these artificial nails and how it's a breeding ground for bacteria, and we just don't want it. Guys, I'm sorry, we just don't want it. You want to keep your nails natural. And just this COVID-19 issue is really highlighting how these germs spread and how easy it is to spread, and how some viruses and bacteria are much deadlier than others and much easier to spread than others. So just to err on the side of caution, keep natural nails, keep them less than 1/4 of an inch long, okay? Always change your gloves between patients. You want to make sure you use an antimicrobial soap and water, and you rub your hands together vigorously for at least 15 seconds. And then remember to use that paper towel to turn off your faucet and open up the door to the bathroom. Not just during the issue with COVID-19, but all the time. We want to practice these things. This is why in any of our science, nursing, and allied health classes, we teach proper hand hygiene and the importance of it. So also you see those in red down there, contact with patients, blood or body fluids, wearing gloves, and eating and using the restroom. We always want to make sure we're using good hand hygiene after all these times. Please make sure that you wash your hands before you eat, and please make sure you wash your hands as you are leaving the restroom. Okay, so, and again, make sure you're checking that textbook, okay? for these. There's some really good pictures in here and some really good resources to help back up what's going on in this lecture. So moving on to approaching, assessing, and identifying your patient. You guys know that this is something we go over and over and over again in lab class. I always say, hi, my name is Melissa. I'm here from the lab, and I'm here to draw your blood, right? The reason I'm telling you that is because out of respect for those patients, and we're delivering the best customer service we can, we always want to identify ourselves to them. Let them know who you are. Let them know where you're from and what you're there for, okay? You also, when you're turning the lights on in their room, keep it as a low-level light as you can for you to be able to do your job. I'll warn them before you turn the lights on, and always make sure you use your inside voice and that you talk in a low voice, okay? So if you enter a room and a physician is in there talking to the patient as you're entering them, what should you do? Okay, the physician-patient relationship has priority over any phlebotomy procedure you're doing unless the request that you had was for a time specimen or a stat specimen. And in that case, any healthcare worker needs to ask for permission from the physician and let them know that this is a timed or stat specimen, and then that physician will let you know what to do next, okay? And these are some things, positioning of the patient and the healthcare worker, that you want to follow. And so I don't want to read each one of these to you, but the main thing is you want to make sure that patient is safe and comfortable, okay? You want to make sure that they're sitting down or lying down, because a lot of people have been known to either pass out or faint, and you would not want them to be in a seat where they could fall out of it and hurt themselves, okay? They shouldn't be chewing anything, food or gum, or have a thermometer in their mouth or anything like that while you're performing a venipuncture, okay? And you want their arm positioning. You want to make sure that you ask the patient to fully extend their arm. And guys, we work on this in lab. You've got to get used to talking to these patients and make sure you ask them which hand they prefer, which arm they prefer. Talk to them. Don't be scared to move their arm around so that their arm is in the best position for you to be able to draw that blood. And like I said, you can pause this, you can rewind it, whatever you need to do to be able to get this information, fill out your study guides, and be able to study for this for our next test. And there's just a lot of useful information in your textbook, so make sure you're going through that and you're reading your textbook, okay? So here's one of our things that we want to use the information that we've learned in lab and lecture and put it together to do some critical thinking, okay? So Ochsner's had a blood drawing area which was a long countertop with high stools on one side for the patient to sit, and an area on the other side of the counter where the phlebotomist stood to draw the blood. Now, use what you've learned. What was wrong with this picture? Again, you guys on these thinking questions, on these case studies, take out a sheet of paper at the beginning of each one of these lectures, and when you get to this part, pause it, write down what you think, and see if you're getting these things right, okay? So, the patient should never be placed on high stools to have their blood drawn. If someone faints, there's no way for the phlebotomist to catch them to break their fall. Somebody could really be hurt. This is a bad idea, okay? So, looking at our test requisition, and I'm sure you recognize that. I'm going to move this around just a little bit, guys. Sorry about that, but I want you to be able to see that. Y'all recognize that requisition from our lab classes, right? And so, like I said, I don't have to read all this to you. You guys have seen this before. The main thing with these requisitions, and in most hospitals, they're electronically transmitted, and they print out, and they have information at the top and their stickers, right? And the information they're going to give you is identification issue. The patient's name, some type of ID number, date of birth, their gender. The tests to be performed are going to be listed on there. The date and time that they requested this test, because we're worried about turnaround time, and turnaround time starts from the minute that test was ordered to the minute those results are put out on that patient, right? The name of the physician that ordered the test, whether it's stat, timed, whether that patient's supposed to be fasting. You're going to make sure that you record the specimen source, because like in Chapter 11, and you should have watched that video before this one, capillary blood is different than venous blood, so we want to make sure the physician's aware of that, because some of the results can be different. There could be some other very pertinent information on these. Electronically generated labels are usually served as the requisition. You want to, those collection requests should be checked prior to the venipuncture procedure, right, to ensure that there's no discrepancies, no missing information or duplicates in the test orders, okay? Because we don't want to be sticking these people more time than they need to be stuck. It is vitally important that you take this test requisition, you go over it thoroughly. You make sure that you are putting against your patient when you are talking to them and making sure that they tell you what their full name and date of birth is, and that matches that requisition form, and their ID bracelet matches it. If not, you need to get with someone to make sure you get this stuff straightened out. Remember, we talked about the 2008 National Patient Safety Goals, okay, that were recommended by Joint Commission. And they have things they set out for is at least 2 patient identifiers, such as a full name and a date of birth, or full name and an address. The patient may be asked to state and spell his or her full name. All of these things are things we really need to do to make sure we are properly identifying our patients, right? So proper identification involves at least 3 steps, right? The patient may be asked to state and spell his or her full name and state his or her name, date of birth, address, or some type of ID number. And they're even doing this at the pharmacy now. If you go to the pharmacy to pick up your medications, they're going to ask you, you know, what's your name, what's your date of birth, what's your address. These are ways for them to keep your information updated and make sure they identify you properly, okay? And you always want to compare the information stated with what's on that test requisition. If there's any discrepancies on that test requisition whatsoever, it needs to be reported immediately to your supervisor, okay? Once you confirm the information with another source, such as the ID on the ID bracelet, driver's license, some nurse or parent is backing that up, okay? So, another think question. Okay, and remember, we have tools for this. Get out a piece of paper at the beginning of this chapter. Make sure that you pause, rewind these when you're filling out your study guides, and make sure you're answering these think questions correctly, because that tells you that you're taking all the information and you're able to put it together to make good decisions when you're out there in the field. So what do you think? Why? Why do you think it is important to have the patient state and spell their full name? To make sure you have the right patient, right? Lots of people have the same name. They may be spelled different, okay? And also, we've talked about this. Don't just say, is your name Mr. Johnson? A lot of patients don't hear properly. They don't hear very well, and they may think they heard the right thing, and they didn't, and they just answer the question as yes, when that's really not the answer, okay? So, why do you think it is important to match the name they tell you with the ID bracelet? And you notice I said they tell you, right? Why? Because you're trying to confirm a second time that you have the right patient. It is one of the most important jobs you have, is to confirm that you are drawing the blood on the correct patient, okay? And then why do you think it is important to match the stated name to the requisition form? Again, you want to confirm a third time that you have the right patient. Why do you think it's important that you draw the blood from the right patient? It could hurt or even kill them if you don't. Okay, so moving on, we're talking about inpatient, outpatient, or ambulatory patient identification. Okay, so because you may not work in a hospital, you may work in an outpatient lab, or anything like that. So there's different ways to do this. Also, make sure, again, you're reading your chapter 10, and you look on page 324 of that chapter. They have test requisitions. It talks about that. It shows pictures. Then on page 325, it's basics of patient identification. Okay, it goes over that all the way to page 326. So really, guys, make sure you're reading your chapter, okay? So hospitalized patients, they usually have that ID bracelet on, that you can take that requisition, compare it to what they have to say, and then compare it to their bracelet. But ambulatory patients, sometimes a lot of them, if they have a bracelet as well, but you might come to a point where there's somebody that doesn't in an outpatient setting, right? Healthcare workers must be careful to state only the name and not reveal any confidential clinical information, especially when they're out in that waiting room where other people can hear, right? We want to keep our patients' confidentiality. And you want to make sure when you're calling those ambulatory patients back, okay, that you're careful not only with their confidentiality, but that you make sure they hear the correct name. That's when we want to make sure we go to the trouble of IDing our patients, right? Some ambulatory clinics issues ID bracelets and some don't. Some have ID cards. You can see that old-timey addressograph imprint machine down there in your bottom right-hand corner. Okay, it's strongly recommended that another form of identification, such as driver's license, is checked. And guys, you really need to go off of where you're working, because sometimes the policy and procedure for your healthcare facility may state that the patient comes in and goes through an initial check. If you see Willis-Knighton, they have a lot of those kiosks there where they come in and they check in there. They have to swipe their driver's license. That's one way that Willis-Knighton and other healthcare facilities have set up a way to do a check on their patient. Then someone sitting behind the counter is going to be made aware that that patient is there for their x-ray, for their lab test, for the MRI. They're going to call them up to their desk. They're going to ID those patients and make sure that it's the right patient. Then they're going to come back to you, and you're going to use that rec that printed out in your lab to call your patient back and to ID your patient. So these are all different ways that we want to make sure we are IDing our patient multiple times. So still on identification of patients, now we're talking about patients who are either comatose, semi-conscious, or sleeping. A patient who is sleeping should be awakened before collecting blood. You always wake your patient up. And we talked earlier about, turning those lights on and things of that nature. If a patient is comatose or semi-conscious, a nurse, relative, or friend may identify the patient. You need to document the individual who verified the identity for you, okay? A nurse, guardian, or relative may identify an infant or a child by providing the name, address, and ID number and or date of birth. Again, the name of the verifier should be documented. So, patients who come into the emergency room unconscious may be provided a temporary master identification until a positive identification can be made. This is that Hollister bracelet, okay? And there are some pictures of some different Hollister bracelets that are out there. These are those patients that may be picked up somewhere that didn't have ID on them, or they weren't able to ID them, and so this is a way for them to do that until they can make proper identification of that patient. So then when a permanent ID is made and a number is assigned, the temporary identification number should be cross-referenced to that permanent number to make sure we're getting that correct patient. Okay, and then we have patients with severe burns or in isolation. Okay, occasionally there are special cases involving patients with severe burns or in isolation in which the identification is attached to the patient's bed rather than their arm. These are the only circumstances in which a healthcare worker may use a bed-labeled ID. But it should be followed up by our nurse's confirmation and appropriate documentation of the process that you used. Okay? So, do not ask, are you Mr. Doe? We went through this, Mr. Smith. Don't do that. And I talked about that because an ill or medicated patient or a patient hard of hearing may just say yes, when you ask them if that's their name when really they didn't hear you or understand you, okay? Do not base identification on records or charts placed on the patient's bed because someone could have accidentally sit down a chart that was not that patient's on that bed, so we don't do that. And do not collect a specimen from a patient whose identity is not confirmed or if there's any discrepancy in the identification process. It's like I said earlier, if you find some kind of discrepancy in that requisition, you need to stop what you're doing and go talk to a supervisor and get that discrepancy straightened out before you draw this patient's blood. So now we're going to move on to venipuncture site selection, okay? And on page 330 in your textbook, we talk about this as well. But the healthcare worker must rely on the senses of touch to locate a vein. Remember, I've always told y'all, you do it by touch, not by sight. And we've went over this in lab. You're going to palpitate and trace the path of the vein in your patient's arm with the index finger on your non-dominant hand, right? And you're going to find that vein, and then you're going to make sure you see which way it's running, how deep it is, all that kind of thing, okay? And you always want to make sure that you have your tourniquet on when you're doing this, but the minute you locate your vein and you have a good idea, you want to make sure that you pop the tourniquet, right? We don't want to leave the tourniquet on too long or have them excessively pump their fist because it causes hemoconcentration, and we talked about hemoconcentration. So sometimes physicians request that veins have restricted use or reserved for transfusions, infusions, and therapeutic agents such as chemotherapy. So when they say that they don't want those veins used, you absolutely do not use them, okay? If no vein becomes apparent, the patient may be able to dangle his or her arm down for about a minute or two to allow the blood flow down to that vein, and sometimes that will help you find that vein. The healthcare worker should never stick a vein unless they can feel it, okay? So, venipuncture site selection, going on from here, and you will see on page 331 in your textbook pictures like this, and we talked about the median cuticle vein, so I'm sorry guys, is the preferred and most commonly used vein for venipuncture. It's usually the bigger, it's more anchored, it's less painful, and it's less prone to injury. So that's the one, if we can find it, we would like to use. The second choice would be the cephalic, right, which lays on the outer edge of the arm. It does not roll or bruise as easy as the basilic. So the basilic is our third choice, and that's when we can't find the other two. The basilic vein is in close proximity to the medial nerve and the brachial artery. That's why we really like to leave that as our last choice. Then we also have the dorsal side of the hand or wrist for acquiring blood. Veins of the wrist tend to roll. If you extend that patient's hand a lot, it'll help position that vein. Ankle and foot dorsal veins should be used only when you have appropriate authorization from your doctor to use that, okay? And there's diagrams on page 332, 333 in your textbook dealing with the veins, and then 334 and 335 dealing with your hand. So make sure you take a look at that, okay? So then warming the puncture site, we talked about this in chapter 11 with capillary punctures. Warming the puncture site is a really good way to increase arterial blood flow, making veins more prominent. Okay, a clean, moist, warm towel or washcloth can be wrapped around the site and encased in plastic for 3 to 5 minutes to warm the site while a specimen is collected from another patient. Tourniquets makes veins more prominent and easier to puncture by slowing down the blood flow towards, thereby causing venous filling, right? Tourniquets are generally about 1 inch width and about 15 to 18 inches long. The tourniquet should be placed about 3 to 4 inches above the venipuncture area. We talked about this in lab, about 4 fingers above that site, okay? So then we've done this in lab, and we've talked about this. How we cleanse our area should be touched by a non-sterile object. Okay, once the site is selected, it should be cleansed with 70% isopropyl alcohol, working in concentric circles from the inside out. The site should be allowed to air dry. Okay, and we've done this in lab. And remember, guys, once you tie your tourniquet, okay, you've ID'd yourself to your patient, told them where you're from, what you're there for. You have ID'd them properly with your requisition form. They're in the seat, they're comfortable, they're safe. You've communicated with them on what site they like best. You've tied your tourniquet on your patient. You use your index finger on your non-dominant hand to locate your vein by feel and not sight. Once you've found your vein, you're going to pop your tourniquet. That's when you're going to take out your alcohol prep pads. You're going to clean your area where your vein is. You're going to clean your index finger on your non-dominant hand, and while they're drying, you're going to get all your supplies together. If you use iodine or betadine, you want to make sure that you remove the iodine from the skin with alcohol after, because it can be an interfering substance. And it can also irritate the skin, and some people even have allergic reactions to iodine. But we would, sometimes in ABG procedures and blood culture procedures, you want to use the iodine, you just want to make sure you remove it. So still talking about the tourniquet, we talked about not leaving it on for more than a minute at a time because it can cause hemoconcentration, and we don't want to do excessive pumping of the fist because that as well can cause hemoconcentration. And hemoconcentration is just the increased concentration of large particles such as protein, cells, coagulation factors, things like that in the bloodstream at that area, and we don't want to do that because it could give us a lot of erroneous results. Here's another one of our think questions. Consider all the locations on the body where it is acceptable for blood to be drawn. In what order should an appropriate vein for venipuncture be picked? First, the arm. We always would prefer to use the arm if possible in most situations, and that's always what we want to use first if we can. And we want to start with that median cubital vein, then if not the cephalic, then the basilic last, right? Second, if we can't find it in the arm, we want to move to the dorsal hand or the lateral wrist. And last, and only with permission, would we do veins of the dorsal foot or the lateral ankle. Why is it important for the patient to wait until the tourniquet is tied before making a fist? Because after the tourniquet is tied, blood from the patient's hand is pushed up the arm and against the tourniquet to pump up the vein. Why should the tourniquet not be left on for longer than 1 minute? It causes hemoconcentration, and we don't want that. Is it possible to tie the tourniquet, find the vein, clean it, and allow the arm to dry and collect the blood in less than 1 minute? No. So that's why you tie your tourniquet, find your vein. Once you find your vein, you pop your tourniquet, and then you go through the process. Okay, guys, this is the first video from Chapter 10. So again, utilize your pause, your rewind, read your chapters, use your fill out your study guides, and start doing this. Remember, our next test is going to be on chapters 11, 10, and 9. So start reading those now, filling out your study guides, and studying. And I hope everybody's doing well. Thanks, and have a great day.